Welcome to episode 240 of Real Health Radio. You can find the show notes and the links talked about as part of this episode at 7, so the word all spelled out, seven-health.com/240. Hey everyone, welcome back to another episode of Real Health Radio. I'm your host, Chris Sandel. I'm a nutritionist that specializes in recovery from disordered eating and eating disorders and helping anyone who has a messy relationship with food and body and exercise. And today on the show, it's a guest interview, and my guest today is Dr. Adele Lafrance. She is a clinical psychologist and research scientist, author, and co-developer of emotion-focused treatment modalities, including emotion-focused family therapy. She is a leader in the research and practice of psychedelic medicine with a focus on ayahuasca, MDMA, psilocybin, and ketamine. And currently, Adele is the clinical investigator and strategy lead for the MAPS-sponsored study of MDMA-assisted therapy for eating disorders. She is also a clinical trainer and supervisor for Imperial College Center for Psychedelic Research. And Dr. Lafrance has a particular interest in mechanisms and models of healing, including emotion processing, spirituality, and family-based psychedelic medicine. So I have been a fan of Adele's work for a while now. I think I first heard her on Tabitha Farah's podcast and have been following her work since then. And as part of this conversation, we talk about how Adele got into working in eating disorders, and she talks about some of the negative biases that she had prior to commencing this work, but then falling in love with it. We go into detail about emotion-focused family therapy and how Adele uses it with eating disorders. She believes in the importance of involving family and caregivers in recovery and explains how and why this can be so helpful. And she goes through the 5 components of emotion-focused family therapy. And then we spend the rest of the conversation talking about psychedelics and how she became interested in them as a healing modality and the studies that she has and is involved in. And Adele really is at the forefront of so much of the research with psychedelics and eating disorders. And so it was super exciting to get to chat with her about this. We had to wrap things up a little abruptly as Adele had to shoot off for a COVID test. And despite all the time we had, there was just so much that we didn't get to cover either at all, or we only sort of mentioned in passing. So Adele has set up the Love Project, looking at research around love and the healing power of it. She has written and worked extensively with parents around raising children. She has a site called Mental Health Foundations that has a ton of information on it. She's done works with schools with emotion-focused school support. So if you enjoy this conversation, just know that there is so many other wonderful things that Adele is doing that we didn't get to cover, but I will put links in the show notes to her various sites and where you can find out more information about her. During the call, I made reference to a documentary on MDMA-assisted therapy, but blanked on the name of it. And it's called The Trip of Compassion, or just Trip of Compassion. And I've added a link to it in the show notes, and I think it is well worth a watch. Adele also mentioned that the trial that she is involved in at Imperial College in London is still recruiting participants. And this is a pilot study looking at the use of psilocybin as a treatment for anorexia nervosa. I put a link in the show notes to the study application page, which also covers the inclusion and exclusion criteria. So if you're female and have been diagnosed with anorexia and you think you might be interested, then please check out the show notes for the link. So that is it for the intro. At the end of the show, I have one new recommendation for a book to check out. But for now, here is my conversation with Dr. Adele Lafrance. Hey Adele, welcome to Real Health Radio. Thanks for joining me on the show today.
Thank you so much, Chris. Happy to be here.
You are someone who has such a depth and breadth of knowledge when it comes to eating disorders. So I'm really excited to be able to chat with you today and share this information with listeners. And there's 2 areas that I'd love to spend a good chunk of time on today. And one is the emotion-focused family therapy and how helpful this can be in eating disorder recovery. And then the other area is psychedelics and their use in eating disorder recovery. And I know you've been involved in a number of studies in this area, and it's something I'm really interested in. So I'd love to find out more. But I want this to be a conversation. So let's just see where things go. And I guess to start with, I think it would be good to give listeners a bit of background on yourself. So are you able to give a bio of sorts, like who you are, what you do, what training you've done, that sort of thing?
Yeah, of course. So I became a psychologist in 2008. And at that time, I had finished a PhD in school in clinical psychology, school and child clinical. So I really expected to be working more in educational settings.
Sure.
But when I was doing my internship, I had to do an internship in an area I knew nothing about. And so they put me in eating disorders. And I thought, oh gosh, I don't know if this is going to be a good fit for me. I'm really not into the therapy part so much. Like I was much more focused on assessment. And oh my gosh, Chris, I just fell in love with the work. I really saw how much more was needed in this area. And so my first job out of school, I decided that I wanted to work with an eating disorder program. So that's what I did. And then I guess within 6 months of working in higher levels of care, I started to think about how we could improve on some of the treatment programs. And over the next 5 years or so, developed emotion-focused family therapy for eating disorders.
And so what was it about the eating disorders that you fell in love with? Like what is it about that work that surprised you and then you just fell in love?
I had a very negative bias towards eating disorders, and when people talk about stigma with eating disorders, in our culture, I know what they're talking about because I had internalized that stigma myself. I really thought negatively, honestly, about the illness, but also about like the people's willingness to recover or seek treatment and so on. Like I'd kind of been exposed to all the stereotypes and unknowingly internalized some of them. And when I met these people, when I started working with these people, these mostly young women and their families, what I saw was these were people who had love for life, but who were also struggling so much that they were trying to find ways to get through, tough times or get through difficult experiences. And so it completely reshaped my view. Often people talk about eating disorders and control, in particular anorexia nervosa, like, oh, it's a disease for control. And I just feel like, looking back, I thought, gosh, we really shouldn't use that language, because if I said to you, like, hey, Chris, I heard you're kind of a controlling guy, I don't know that you would take that very positively. In fact, I'm pretty certain you would take offense to that, Yeah. And so that in particular, I was interested in, like, what's this whole control thing about? And what I realized, both through practice, but also, through research, was that this desire for control, it's about controlling one's experiences of suffering. Yeah. It's not about controlling one's environment or one's loved ones. It's that, like, I am suffering. I'm suffering so much that my nervous system is feeling out of control and it's really hard to be in my body. And so I need to find some way to get some relief. So those were kind of some of the things that made me feel very passionate and very committed to helping. And then the other piece was the family piece. Like in the past, families were really seen as causal factors, in particular parents. And I was being trained right at the beginning of the movement towards increasing family involvement for meal support, for symptom interruption, and so on. And, again, I had internalized that same bias, especially when I reflected on my courses early on in developmental psychopathology. Like, a lot had to do with the parents. And
Yeah.
then when I was working in eating disorders, it's like that field seemed to be more evolved than the other fields of mental health, where like, yes, okay, there are factors that can contribute, but no, these are not causal factors. And yes, parents can be a huge part of the solution. And anyway, so the more I worked with parents, the more I saw that how they were treated. Also, I thought, okay, like we really need to do something here. So anyway, so there began my commitment, to working with eating disorders and trying to find better ways, not just for individuals, but for families too.
Yeah. And it's interesting, your comments about the control piece, and really makes me think of the Gabor Mate comment around like addiction, like rather than asking why the addiction, asking like why the pain.
That's right. Exactly.
And just using that as a point of reference and starting to really understand that this thing that can be completely debilitating for someone and could be causing huge amounts of issues for physical health, mental health, etc., is also someone's solution. And it's a solution that in many ways works very effectively for someone, despite all the collateral damage that is being caused. And being understanding of that and really trying to get a sense of, okay, well, what is this really doing for someone?
Yeah. And also to underline, it's like, it's never someone's first solution either.
Yeah.
Like people don't go to that solution first, consciously or unconsciously. It's when people are feeling desperate, and out of control and like in serious pain.
Yeah. And with your biases, were they things that you had through growing up, or they were more cemented when you then started studying psychology?
I think it's probably I think it was a combination of media and also when I started studying psychology, because I didn't really have any exposure to eating disorders growing up. I lived in a really small, very homogeneous village, in northern Canada. And so I don't know that I would have adopted those ways of thinking that way, but I think for sure media messages would have played a role, and my training for sure, in particular around the parenting piece.
Wow. And do you think, you've been out of school for quite a while now, do you think that training has changed, or do you know if that training has changed?
I don't know, because I haven't been exposed to other programs, educational programs for some time. I know that up until a few years ago, I was a faculty member teaching clinical psychology students, and I certainly was ensuring that the curriculum was evolved, so I think it's getting better, but I think we have a long ways to go, because when I do trainings in emotion-focused family therapy, I have the opportunity now to be exposed to thousands of clinicians, each year in these settings. And I can tell from those experiences that we're not quite there yet. People are working really hard, and we can only do the best we can given the information we have, and the training that we have. But yeah, we're not quite there yet.
Okay. And you said that you'd originally done a PhD. So were you thinking that you would be a research scientist and that would kind of be your main thing?
No, in Canada, you could do a PhD in clinical, which then prepares you for all different pathways. You can be a research scientist, or you can be a registered, clinical psychologist. And so I started off as a clinical psychologist working in eating disorders. But then after a few years, I actually then took an academic position so that I could do research, do research in particular around eating disorders and emotion-focused family therapy.
And for doing research, for like, I have a real calling for research, or I think this would be very practical to help me be a better clinical psychologist, or what was the reason for that?
Oh, I really had a strong call for research. I really see the value of research in terms of being able to change the landscape, on a broader level. I also, of course, believe strongly in the reciprocal influence on clinical practice, but I see research as a vehicle for change, a vehicle for advocacy. And I really felt like there were some studies that I wanted to do in order to help change the conversation and eventually the way we practice, in particular with parents. And there's one study in particular that I was like really happy about, that showed that when parents of kids, teens, adults with eating disorders engage in accommodating or enabling behaviors, they're not doing it because they don't get it. They're not doing it because they're not motivated to help. My research showed that when they engage in those practices, it's because they're terrified that if they don't, their loved one will suffer so much that they might consider suicide, or that they might totally block them from their lives, And so that was the piece of research that I was the most happy about, because it was like scientific evidence that there's no such thing as a unmotivated parent who doesn't get it. There's a parent who's afraid and who's paralyzed by their fear, and who's, engaging with their loved one in a way that makes them feel like it's less risky than, potential loss of relationship or death.
Yeah.
And that's huge. That's so huge. And I was just on a consult call 2 weeks ago to do like a little training for this group, and heard, they were talking about a case, and they were talking about it in the way that I really would like to evolve from, like, parents just don't get it, or they're enmeshed, or this or that or whatever. I'm like, no, let's not talk about it like that. Let's talk about it more accurately. And thankfully, more compassionately. Like, these parents are stuck in a bind. If you were presented with two choices, whether or not they're real, do you want a sick kid or a dead one? Like, anyone would choose the same thing, anybody. And so that piece of research was the one. I'm so glad I went back into academia for that period of time, just for that study.
Yeah. No, that's you. And look, I don't work with kids. I work with adults, but I often have conversations with partners.
Yes.
I just feel for someone who is a partner of someone suffering with an eating disorder, because it is so complex, and it's so difficult to get your head around, like, what is the right thing to say and do. And there is the fear of saying and doing the wrong thing. And so, even with parents who have the best of intentions, they just, I mean, I have a 4-year-old child, and I know how difficult it is.
Exactly.
And so, I do. I think less of the blame, and that research showing that there shouldn't be the blame, I think is all for the better.
Well, honestly, not just no blame, but many, many programs. And by the way, this research was conducted a lot along the lifespan. So it wasn't just kids, it was partners, parents of adults as well.
Yeah.
And so it's like, number one lesson is like, no blame. Number two lesson, though, is we tend to start working with parents, spouses, with providing them with education.
Yeah.
But what my research is showing is that they're scared. And so when someone's scared, their capacity to learn, is limited, because the emotion is strong, and therefore it's impairing their capacity to encode new information. And so, when I look at psychoeducational groups or friends and family support groups, like, most often the first session or the first few sessions are psychoeducation. And from an emotion-focused point of view, that doesn't always make so much sense, because if anything, we should be starting with tending to their fears.
Yeah.
And really allowing them to speak those fears, so that those fears can lose some power and they can regain some cognitive flexibility in the face of some of those more challenging situations. And that study that I talked about, it wasn't just fear, it was also concerns around blame. How much they felt people blame them, how much they blame themselves, how worried they were about being to blame if they did take on a role in their loved one's healing and it didn't go well.
Yeah.
And that's something that I feel like we don't talk about enough, especially when we talk about parent empowerment programs.
Yeah.
Or caregiver empowerment programs. It's like, okay, well, if it doesn't go well, and the program is based on empowering parents and spouses, to support their loved one, how does that leave the family, and what can we do to support them, so that they don't end up internalizing the blame?
Yeah. Well, thank you so much for saying that, because I'm going to keep this in mind anytime that I'm then having a conversation with a partner or a loved one, and start there, because I do that's a really important point.
I'll tell them that if it doesn't work, it's on us. We didn't do it. We didn't support them right. We didn't have the timing right. We're supposed to be the professionals figuring out the right algorithm for the right family. And if it doesn't work, it's on us. That's one of the things that I do.
So you've touched a little bit already on the emotion-focused family therapy. So I guess it would be good to just go into this in more detail. So what is emotion-focused family therapy?
Well, it started off as an adjunct to family-based treatment for eating disorders. I was working with teenagers in a day treatment program, and I'll never forget when the mom of one of our patients came in and talked to us about plates flying in the kitchen. There was just so much stress and distress around the mealtime. And it was so uncharacteristic of this young woman who was a straight A student, mild-mannered, never said boo to authority figures. And she's throwing plates in the kitchen, for real, seriously, danger. And I remember feeling oh my gosh, I have no idea what to do here. And what we were trained, or what I understood from my training, was, just be bigger, stronger than the eating disorder, just be a brick wall, But I did not feel good about that, because I really worried actually about some families then having to eventually heal from the trauma of treatment.
Yeah.
And you'd see some families would drop out because they're no, this is traumatizing. We can't also be dealing with this. And so that's when I started really kind of seeking out what else. And I was learning about emotion-focused therapy at the time. And I was being trained in emotion processing skills to support clients in individual therapy to move through big, intense, powerful emotions. And I thought, okay, we need to teach parents these skills. And specifically, we need to teach them in a way that will support mealtime.
Yeah.
And so I worked with other people over the years, and we tried to kind of language it in a way that would be, appropriate for all levels of education, experience, so on. And we developed this adapted model of what we call emotion coaching. And for eating disorders, we start with the application of emotion coaching for meal support and symptom interruption, because that ends up being, one of the most important things. And then as that moves along in a good way, then we'll start to target some of the emotion processing difficulties that are fueling the symptoms. So I'll give you an example. Many individuals with anorexia nervosa have really a very hard time with anger.
Yeah.
And so we would teach the parents, spouses, alternate caregivers, these emotion coaching scripts to respond to resistance at mealtimes. And then we would also teach them emotion coaching scripts to support their loved one in their capacities to express anger. And it's pretty magical when someone who has anorexia develops comfort and skill with the expression of anger. Restriction is not as necessary.
Yeah.
And we see the same thing as dramatically in individuals who self-harm. So, anger ends up being a very powerful healing tool, but we have to do prep work with the family, because in our culture, anger is seen as harmful, hurtful, or disrespectful. Yeah. And so we do a lot of work with the family to be okay, this is why we want to work on this, emotion, because physiologically it's the opposite of anxiety. It's the opposite of hopeless despair. And there's this emotion theory that shows that if you activate two opposing emotions, they could neutralize one another. And so anger is thrusting forward, anxiety is sulking back. If we can work with both of those emotions, then we can actually neutralize its experience create calm, create peace, inner peace, So we're teaching them the emotion theory as well as teaching them skills on how to work with anger in particular in a good way. So that's one kind of area of EFFT is the emotion coaching.
And are you doing this with both the parents and then also the client or the patient?
Well, you know what? We developed EFFT so that the client did not have to be involved at all if they did not want to. And for a number of reasons, many clients did not want to be a part of this work. And so we needed to find a way for it to be okay. The other piece is that in Canada and the US, if a client has to give consent to reveal personal health information to their parents and caregivers, it's not like in the UK where you have caregiver, legislation to protect caregivers' rights.
Yeah.
And so we needed to develop a treatment that could be delivered to caregivers without any personal health information of the client being given, just in case. So it can be done with, it can be done without.
Okay. You said that was the emotional support piece.
Right. So the emotion coaching is the one module of EFFT. The other is behavior coaching, but it's most well known in eating disorders, where we encourage caregivers to support with the behavioral symptoms. So that's the meal support, the symptom interruption, but those two modules need to go together. The emotional support needs to go with the behavioral support so that we can avoid that need for the brick wall or, high conflict situations or even violence, aggression at the dinner table, and to preserve the relationship, frankly, because it's really tough to go through this kind of treatment. So those are the first two modules. The third module is called therapeutic apologies. And this is such a fascinating module for me because at first we developed it to help heal relationships that were strained or estranged between parents and children, so that the parents could then get more involved in the hands-on stuff, right? So if the relationship was estranged, naturally we needed to do a little bit of that healing work, to kind of open the door for the other stuff. And so that's what we did. But what we found was really beautiful. What we found is that when we supported parents to engage in a therapeutic apology with their child or their loved one, somehow, not only did it strengthen or heal the relationship, but it also healed both parties from narratives of self-blame. So the kid felt less to blame for the eating disorder. The parent felt less to blame for the eating disorder, and they felt more connected.
Wow.
So that was very unexpected. And so I've been working on that module maybe the most over the last 5 years.
Yeah.
Just tightening it up, strengthening it. And so it's very powerful, and it's a very it's short. I mean, it's not like weeks and weeks of work. It's like 2 to 3 sessions. And the other thing we found, and I'm sure some of your listeners who work with eating disorders can relate to this, even if a parent-child relationship was strong.
Yeah.
If the child had an eating disorder that was really, really sticky, like the kind of more, the one that's like more entrenched at the brain level, like much more rigid,
Yeah.
Even if the relationship was strong, if the parent facilitated a therapeutic apology to strengthen the already strong relationship, it actually improved or made more efficient the parent's efforts. Because the parent's efforts, like if you imagine like a roadway between the parent and the child, and the roadway represents the relationship.
Yeah.
If it's a dirt road, or if it's a regional road, or if it's a highway, the efforts kind of traverse more easily or with more challenge.
Yeah.
And so it's the same, if we kind of think about it that way, it's the relationship. So I worked with a family where the relationship was like a highway. It was really wonderful. And so parents' supportive efforts would zoom over, really well, really beautifully, really efficiently. But their kid had a very, very sticky eating disorder. And so when we did the therapeutic apology, what it did was it upgraded the highway to a superhighway, which meant that when the parents, even the therapists, were engaging, with the patient, their efforts were more effective.
Wow.
So it's like a brain hack.
Yeah. And in real terms, like what does a therapeutic apology look like? Or what, like how does that happen? What is it?
Yeah, so it's an apology, so as the name suggests, and it's an apology that the parent or caregiver delivers to their loved one. There's 5 specific steps, and they identify a pattern or an event that they feel could have impacted their loved one in a significant way. And they basically communicate an apology for how it went down, including validating their different types of feelings: sadness, fear, shame, and anger. Now, some people at the very beginning were like, wait a minute, how could you have a no blame approach, but then ask parents to apologize for something, And I think that that's more of a cultural thing. In different cultures, apologies mean different things.
Yeah.
In North American culture, apologies often mean responsibility, fault.
Yeah.
Whereas in some Asian cultures, apology means an expression of validation, of deep validation. And so that was the first thing I needed to kind of work out for my audience. I was like, okay, how am I going to communicate to a mostly North American culture that this therapeutic apology has nothing to do with blame?
Yeah.
It has nothing to do with responsibility. It's a deep validation. And so one of the conditions of doing this therapeutic apology is that the parent or caregiver must be able to hold in their heart that they did the best they could, given their circumstances, given the information they were exposed to, given their own experiences, given the state of the literature, given the state of our clinical practices, that they have to be able to hold that truth. And so when we're trying to help them to identify what they could apologize for, we'll say, okay, imagine on the day your child was born, they were given a crystal ball. And then with that crystal ball, you're able to see the unfolding of all things. And you're privy to all of the most up-to-date scientific information that we now have.
Yeah.
And you have access to all the financial and social support resources that you could need. What would you have done differently?
Yeah.
See, so it's fantasy. It's not reality. Like we're not asking parents to say, man, I really should have done that. Like for real. No, yeah. I mean, they did the best they could with what they had. This is an expression of deep validation.
Yeah, and that makes complete sense because you don't know how things are going to turn out, and you are doing the best that you can. And hindsight is a wonderful thing of like, oh, I would now do this differently, but I now do this differently because I've seen the outcome that has occurred. I've now read a ton. I'm now experiencing all of these things that I had no idea was going to occur. And so
that nobody knew. Like if you look at some of the advice that eating disorder professionals were giving 10, 20 years ago.
Yeah.
Like, not so good. Like, or the medical community, like we're not, like no one is spared here from this notion of like, when we know better, we do better. So there truly is no blame. It truly is no blame, especially when we kind of zoom out and look at the last 3 generations in our culture. Yeah. And also these really deep validations can be so powerful. In fact, I wrote a standard apology that any human in relationship in our cultures can deliver to another. Yeah. And I wrote that because number one, I really believe in giving parents and caregivers scripts, to kind of be guided by so they can make it their own. I wrote that for that reason, but I also wrote it for them to see, like, this is really no blame. Like, look at anyone could deliver this apology to anyone else. And it's about emotional unavailability.
Yeah.
At this time in our evolution as humans, it is impossible for us to be there for our loved ones in all the ways because we need to feed ourselves. We need to void. We need to sleep in order to recharge. And then add, the other pieces of our world. We have to work.
Yeah.
We have to relax. And so it's actually physiologically impossible for us to be there for our loved ones in all the ways they need, want, and deserve. And so I constructed this standard, universal apology is what I call it, because we can all communicate it. And when someone receives an apology like that, it feels so good, because the other side of this coin around apologies is that our culture has an aversion to apologies.
Yeah.
Instead, they want to explain, like, here, let me explain to you why this happened so that you see that it wasn't personal. Unfortunately, the brain doesn't work that way, at least not yet.
Yeah. Yeah. And I think
the solution.
Your word before, like validation, when you hear an apology, you just feel understood and validated. And even if that's not the other person taking full responsibility, it's still, it hits you very differently.
That's right. And the brain, the cool thing about the brain is that when we're having a strong emotion, we're having a painful emotion, if someone else, if the external environment can speak our internal experience, then automatically the brain's alarm bells start to reduce in intensity.
Yeah.
And so that's why validation is so important, and why I believe it's such a worthwhile skill to learn, because that's how the brain works. Like, if my brain is like really scared, it becomes less flexible, it becomes more tense. But if you say, Chris, to me, Adele, I could understand why you'd be scared, because this is the first time that you're doing this. And because the last time you did it, or the last time you did something similar, it didn't go so well, and because you're really worried about not being able to handle it. Some people think that has the risk of increasing the feeling of fear, but actually the neuroscience of validation is showing that it has the opposite effect. Speaking the fears creates a sense of togetherness, and it brings them down. Now, you don't end there. You then want to offer some support, emotional support, practical support, and that's all in the EFFT model. But it's a really different way of looking at response to emotion based on what we thought we knew.
Yeah. Yeah. I know, just the way you phrase it there is how I speak with clients as well. And I think when I was reading through emotion-focused family therapy as part of the prep for this, like the thing that jumped out at me as kind of like the big meta piece with this is just learning perspective taking. And feeling like the other person genuinely gets a sense of what you're going through. And it doesn't mean that you then have to jump in with that other person and both of you are then drowning, but where you have a sense of like, I can get why this is so monumentally difficult for you, and that this feels like the scariest thing that you've ever had to do, and that it completely sucks that you're in this situation.
That's right. That's right. Exactly.
Yeah. And then there's a fourth domain, which is then the fears and obstacles.
Oh, right. Yeah, there are two more. So those are the 3 modules of intervention that we teach the caregivers. So behavioral support, emotional support, therapeutic apologies. But then there are 2 more modules. One relates to caregiver blocks. So remember I talked about earlier, when parents engage in ways that are problematic, it's not because they don't get it. It's not because they don't care, but it's because they're paralyzed with fear or with shame or in grief, some emotion that's impairing their capacity to engage differently. And so whenever an emotion like that emerges and is interfering with their capacity to offer behavioral support, emotional support, or therapeutic apology, then we take a pause and we work on that block using different tools and techniques from the model. And there's almost a dozen different ways that we help parents and caregivers extricate themselves from that rock and the hard place.
Yeah.
But I think that's the greatest value in EFFT is that, well, at least from what I've seen, is that there are a few other models that tell you what to do when what's supposed to be happening isn't happening. And there are a lot of options, but to take it one step further, the 5th module of EFFT and the final module of EFFT is called clinician blocks.
Yeah.
And that module gets activated when the clinician is, losing faith in the parents' capacities or the client's capacities for change, or they're experiencing negative feelings or having negative reactions to the family, or they've lost courage to bring up, the module on therapeutic apologies because they're worried that it'll be taken the wrong way. So they are avoiding it, so any way that clinicians consciously or unconsciously interfere, with potential recovery efforts or treatment. And like, we're all human, we all have the same kind of brain. It functions similarly. And so, of course, if parents can get paralyzed by fear and that affects the way they care for their loved ones, clinicians can too. And we see it all the time. We just don't talk about it as much. And so one of my goals with EFFT, in particular with the clinician domain, is to make it totally normal to talk about, like, I got triggered by that family. And when I got triggered, this is how I behaved, in a way that wasn't necessarily so good for them. I feel like we're doing a much better job as clinicians, being able to talk about being triggered.
Yeah.
But we don't talk about the things that we do when triggered that are not flattering. Not nearly enough. I don't hear enough clinicians saying, you know what, I tried to discharge them early because I was really activated by them and frustrated by them.
Yeah.
So I feel like we have some work to do, and that's not the clinician's fault. That's a cultural thing, like we're trained to be self-reflective but perfect. Like I remember, like, in PhD, I remember where I was sitting in the classroom because it stuck with me so deeply. The professor said, you've got to leave your shit at the door. And first of all, I was kind of like, oh, she said shit, like, oh, okay. I'm like, yeah, of course. You got to leave your shit at the door. Of course. But then I remember having a moment in, like, 5 seconds later, how do you do that?
Yeah.
And now that I know a little bit more about the nervous system, it's actually not possible to do that.
Yeah.
And so for decades, clinicians have been ill-equipped to recognize triggers.
Yeah.
But also to respond to triggers in a way that is compassionate. Because if anything, for the first, few years, I felt totally ashamed.
Yeah.
So we have work to do there too.
Yeah, definitely. And I'm what you said there kind of reminds me about some of the stuff that Brene Brown's talked about with kind of the shame response and how much that can then just completely hijack the way that you are in certain situations and the way that you react. And you're completely right. Like, the nervous system just takes over. I think we as humans are less in the driver's seat than we like to think that we are. And we are so at the mercy so often of things that are connected to things when we were growing up and the way we were parented, the way we got attunement or attachment, like all of these things that we just don't recognize of how much they are having an impact. And we are then just in the situation and we are just in that state. And we feel like, okay, it makes sense to kind of be here or whatever, and that we're in the driver's seat and taking us there. But I think we are much more reactive than we like to think that we are.
Well, and also I'm going to just point out something really subtle. I hope it's okay. But when you talked about like what we're affected by, you basically said our childhood and our parents. I would say our cultural conditioning.
Yeah.
Because then it takes it off the parents.
Sure.
You know, because it's so subtle. It's so subtle. But it really is about the cultural conditioning, because that's how parents learn to parent from their own experiences, but also how did they get their own experiences by the cultural demands that shaped, their parents, et cetera, et cetera. But you're absolutely right. And so I feel very strongly that if we're working in eating disorders, because they are high stakes, because they are high stress, that clinicians need to be engaged in contemplative practices, preferably some sort of psychotherapy, because you can't be in those kinds of stressful situations where some people really are at risk of death.
Yeah.
because we get way more activated. And like you said, when we're activated, we're not in the driver's seat.
Yeah. Yeah. And look, I take your point. And yes, what I was trying to say was like just the environment we grow up in.
Totally.
And yeah, it's definitely not just parents, it's school, it's the media, it is everything. And yes, that has an impact on us in ways that we fail to see.
Yeah, and I mean it's war too. It's sociopolitics. There are all kinds of things that have shaped us for generations that are not currently active right now. Like if we look at the impact of war on emotion processing, people who are on the front line are taught not to show vulnerability. And it's good advice. But when those people go home and they see their toddler, and they're traumatized, and they see their toddler, or their child is crying or feeling scared, what's their knee-jerk response from that trauma response? It's like, don't show fear, don't cry, and then these practices end up infiltrating the parenting context, and then they get passed down. And so it's not just what's currently active, it's what's come before us also. And I think about like people of color, who were marginalized or worse, if they showed anger, I mean, it could be a matter of life and death for them.
Yeah.
And so, of course, it would make sense that through the generations that they would have transmitted these practices from a place of survival. So there's a lot of cleanup to do in aisle 5, for all of us in terms of how we work with emotions. And it's nobody's fault. It really is nobody's fault.
Yeah. Yeah. And it's amazing how when we think about time, that the generations aren't that long ago. Like my grandfather was in the Second World War. And his dad before him was in the First World War. And that's like, we're not going back that far. And I like to hear about what happened as part of them and how horrific all of that was. And we knew so little about trauma and everything. And that was just basically everyone's experience. And so, it's had such an impact for so long, and we're just starting to. It feels like we're at the real starting point of really beginning to grasp this.
That's exactly right. And I wrote this quote to try to communicate what you've just communicated so beautifully. For parents, caregivers around the therapeutic apology. Yeah. And I can't remember exactly. It's on one of my slides, but it's apologizing doesn't mean you are to blame. It means you are willing to shoulder some of the burden of the generations past.
Yeah, that's lovely.
And to create that change for the generations to come. That's what it means.
Yeah. And so one of the things that is used, I think, as part of EFFT is block chair work. I saw on your site that you were doing like training on that and talked about it as being like one of the fundamentals or like really important as part of it. So what is block chair work?
So it's an intervention. It takes about 25 minutes. And it helps a parent or a caregiver who's stuck in fear, who's stuck in a problematic pattern of supporting their loved one, to get unstuck. And we use chairs just because we need to activate different emotions so that we can use their transformative power. That sounds kind of silly talking about it like that without seeing it. But the first thing, like, so if a parent said to me, I really don't want to insist that my child eats the snacks in between. Like, I'm worried that it's going to be too much for her, that she's not going to want to eat it all anymore. And so like, I think I just want to do breakfast, lunch, and dinner. And I'd be like, okay, come over here, come sit in this chair, picture yourself in the other chair, and be the part of you that tells you, don't do it. It's too risky. And within 10 or 15 seconds, the caregiver reveals to us their deepest fear. Don't do it. It's going to be too much for her. She's going to get way too upset. And when she gets upset, she gets completely overwhelmed. She might kill herself. She's tried before, And this time she might actually, go all the way. And so when we're having the parent express their deepest fears like that in the presence of a supportive other, it naturally has an effect of reducing that fear. And so then we'll ask them to picture their child in the chair opposite them and let them know, like, sweetheart, like I love you too much. I'm too scared. I can't lose you. I'm not going to push you further than those 3 meals. We're not going to do the snacks. And then we have them switch to embody their child, to see what it's like for their child to hear that. Well, oftentimes it would be like, oh, thanks, great. I don't want that either. I appreciate you respecting my wishes. But then when we ask the parent to see if there's anything underneath that, to dig a little deeper, what's often revealed is their child's true wishes, which is, yes, I need help. I will never be able to do this by myself. There's a part of me that just can't let myself eat, but I need you. And so I need you to really help me with these snacks, but I need you to do it in a way that is, less like a brick wall or less forceful or less jarring, And so they get to the nuance of what the child needs in a way that I haven't been able to replicate using other interventions.
Wow.
And so then the parent, like, what happens is when the fear is out of the way, when you've named it, you've had it validated by your therapist, we're not problem solving it, but we're just really, really deeply allowing that fear and validating it. Then what happens is that the person has a capacity for flexibility once more, and for creative problem solving, and for empathy. And through that process of embodying their child, they get to re-engage with their caregiving instincts. So there's many more steps, but you see, there's no part of me that's saying, oh, I don't think what you're doing is right, to the parent.
Yeah.
It's like, no, let's see why this is important. And let's see if we can't find a third way. So that's that's the objective, is to work through the emotions that are driving the problematic pattern, but also resume flexibility, access to caregiving instincts so that they can find a third way, a fourth way, a fifth way.
Nice. In a sense, it's like kind of, let's get all the cards out on the table and have a look at like all of these different aspects.
Yeah.
Because I think the more you take the approach of, I'm going to tell you all the reasons why you need to do this for your child, the natural human instinct is to then find the counterpoints and be like, no, these are all the reasons I shouldn't be doing this. And so it kind of then just leads to more butting of heads, or more of someone feeling more entrenched in that view, as opposed to, well, let's actually explore this. And as you say, like, let's look at what's underneath and why this is driving the desire to go in this direction.
That's exactly right. And it becomes even more intense when you as a parent think that the interventions that the clinicians are suggesting might lead to your child's death. Yeah. By suicide, and like, I use that example because it's the most powerful one. But yeah, it's not just butting heads at that point. It's like, if you stop trying to convince me to do something that I feel will lead to a much worse fate.
Yeah. Yeah. And it's great that you've then got a method of being able to do that, because what you're talking about here, it reminds me, I had a podcast interview with Josie Gello. Do you know Josie Gello? Yes. And there seems to be a lot of overlap in terms of the way that you guys speak and the way that you think about this. And she's done a lot of great research around like how to be supportive for the child as the parent, and also as the provider, and a lot of stuff on compassion. And it was a really great conversation. And it sounds like a lot of what I talked about with her is also what you're talking about, but having it in a more practical way of like, this is the steps of being able to do this.
That's right. Yeah. And teaching the parents those very same steps.
Yeah. Nice. Okay. This is great. And I also remember you saying that by doing this as well, like from the eating disorder sufferer's perspective, it then starts to decrease the alarm within them. And it then just that validation piece then is so helpful in a sense, like regulating their nervous system, as kind of counterintuitively as that may sound. Like by speaking the fear, it actually helps to reduce everything.
Exactly. Yeah. And there are many different definitions out there of what it means to validate. So I just want people to know that this definition is a very specific, step-by-step technique. Because that's what we encourage people to learn for sure.
Yeah. And I know when looking at the research that you had on your site about this, a lot of it talked about like a 2-day intensive course. So is that how it's normally taught, or is that how you're normally teaching it?
Well, no, we do all kinds of different formats because we do believe that a little bit can go a long way. And so for parents and caregivers, they can participate in 3 or 4 hour workshops, or they can do the full 2-day workshop, or they can do a full course, of therapy. But for clinicians, same, they can start off with the 3-4 hour workshop, do a couple days. It's like this. I feel that this model is best learned with repetition over time.
Yeah.
So you do a little piece, integrate it, do another little piece, integrate it, do a couple days, integrate it. And then it becomes much more internalized.
Yeah. Okay. Nice. I think that's great. And so I want to now switch and talk about the second topic, which is psychedelics. And so, how did you become interested in psychedelic research and the resurgence in psychedelics?
Yeah. Well, it's funny because I have like no history with psychedelics whatsoever. I was not one of those teens or young adults who experimented with psychedelics. In fact, they scared the crap out of me. I wanted nothing to do with them because I knew that my brain was going to be my biggest asset in life. I wasn't athletic. I wasn't artistic, but I knew how to do school, so I really stayed away from any of those things. But much like I developed EFFT through desperation, like I was saying earlier, I didn't know how to handle these situations. They were serious situations. And so that drove me to learn as much as I could about different aspects of the field of psychology.
Yeah.
And then, even with EFFT, we're not able to reach everybody. I feel like we're doing a really good job, but not everyone responds in the way that we would like. And so you mentioned Gabor Mate earlier. I was a huge fan of his, and I'd read all of his books, and he was presenting in my hometown. And so I went to watch him present. And then someone in the crowd asked him a question about ayahuasca during the Q&A. And he responded in an interesting way. He's like, well, I'm not really here to talk about that. We're here to talk about trauma, whichever topic it was, I can't recall. It's like, but, if you're interested, there's going to be a documentary airing this Tuesday on The Nature of Things, which is a well-respected science show in Canada. And so you're welcome to view that. And I thought, oh my gosh, I'd never heard that word before. I'd read every single one of his books. I went home, set the recorder for Tuesday, and I watched this documentary on ayahuasca, which is this indigenous and very psychedelic plant medicine from the Amazon, which has been used for centuries. And he was using it with people suffering from really severe drug addiction and having some pretty miraculous results from what I was observing. And so I thought, oh my gosh, this could work for eating disorders. And so I emailed him and I told him, I'm a professor, in Canada, work with eating disorders, working on developing new treatments, told him about EFFT. I just saw this documentary. I need to know more. People with eating disorders and their families are suffering so much. We need new treatment options. Can you help?
And how long ago was this? What year was this?
That was in 2013.
Okay.
And then he didn't respond. And so I wrote him again because I could not stop thinking about it, especially every time I went to work, and saw patients.
Yeah.
And he responded, and he invited me to attend a retreat that he was going to be facilitating abroad. And he invited me to attend both as a participant so that I could experience it, but also as a mentee, as a trainee. And I was so scared. I'd never done anything like that before. But I was actually going through a really hard time personally because I was struggling with going through IVF treatments, in vitro fertilization. And so I thought, well, okay, I'm going to give it a shot. And so I went. And I had a very, very powerful experience, life-changing, as many people say.
Yeah.
But the other thing that happened was that I observed that at least 1/3 of the people who were at this retreat had either full-blown eating disorders or a history of disordered eating. And the kind of healing that I was witnessing in that 8-day retreat was mind-blowing.
Yeah.
And so I remember saying to Gabor at the end, I'm like, we need to do research for eating disorders. And he looked at me, he's like, no, you need to do research. He's like, that's not what I do anymore. Like he's advancing in his age/career.
Yeah.
And so I went home and I put together a research team of well-respected psychologists and policymakers and conducted our very first study on eating disorders, looking at people's experiences with ayahuasca when they'd already been diagnosed with an eating disorder. And it was really great, got a lot of press, and got a lot of interest. And then Rick Doblin from MAPS, the Multidisciplinary Association for Psychedelic Studies, heard about my work and then asked me if I would be the lead on a study for MDMA-assisted psychotherapy for eating disorders. And then through that work, I got connected with Imperial College to join as a collaborator on their study on psilocybin-assisted psychotherapy for anorexia nervosa. And in somewhere in between, conducted a study on the potential of emotion-focused ketamine-assisted psychotherapy for eating disorders. And so you see, it was all very organic. And now, I'm involved in all of this research. And people will consider me, one of the leaders in psychedelic medicine for eating disorder, but it's actually not true because we don't know anything at this point.
Yeah.
I shouldn't say that. I mean, we've done a lot of work preparing for these studies, but they're just now launching. And so at this point, we have speculations, we have theories, we have a lot of optimism. But we're still at the very, very beginning, of understanding what this potential might be.
Yeah. Yeah. And look, I'm very interested in this just because I have a huge amount of hope for this and see the potential for how useful they could be. And I'm glad that there is this resurgence. I'm glad that they are starting to do studies around this. But yeah, you're right. Like it is very much the beginning stages and doing studies with small amounts of people in the whole scheme of things. And so it's going to be a number of years or more than that as things progress. But I am, hugely optimistic and excited about this.
Yeah, no, me too. I mean, and I think we need to kind of keep talking about the potential issues.
Yes.
So that we can do it in a good way. Like I was just, and this week I got an email from a group in Europe who want to start a study with young adults in one of the psychedelic compounds, and they wanted my advice. And I got a little flash of worry, because I didn't get the sense that anyone on the team was really embedded within the eating disorder field. Yeah. And it sounded to me like they were developing a protocol that was just for the individual with the eating disorder. And the field of eating disorders has done so much in the last 25 years to demonstrate scientifically even the importance of systemic involvement with families, loved ones. And so I am a little tiny bit worried that we're going to repeat some of those mistakes because, I guess what I'm saying is like, it's a call to action for folks who are in the eating disorders field and who have been, for a number of years to see if we can't convince those in the psychedelic sciences to partner with us so that we can combine the best of what we've been able to learn and do in our field with these new compounds, that are showing such great potential.
Yeah, because I think that's the thing that people maybe need to understand of like how, doesn't matter how powerful these substances are, it's not just the substance. It's then that in
That's right.
conjunction with therapy. And so, yeah, I think that that's the thing that people need to really get. And like, as you say, like incorporating into what you're already doing, and then having this be something that can, in the best case scenario, is really smash the doors wide open, and speed things up.
Yeah. Or gently open the door,
Or gently open the door.
When someone's been terrified of what's on the other side of it. But both could be true. We just don't know, and that's one of the things that I've incorporated in all the studies, or I've advocated for the incorporation of in all the studies I'm a part of, is family involvement, having a role. Because if the door does get smashed open, that's really hard for the system.
Yeah.
Right? Because there's such a dramatic change, even if it's positive.
Yes.
And the system needs to be supported to adjust, to that major change. So yeah, there's still so much to consider and so much to kind of reflect upon. But I like you, Chris, I'm very hopeful, in particular because I've gotten to know most of the researchers who are conducting these studies, and not only is their heart firmly in the right place, they are really, really smart people who want to do this the right way. And so there's a lot of reason for optimism.
Yeah. And so I think it'd be useful to just go through each of these separately and just kind of talk about what some of the studies are, or what are some of the things that you've seen as part of this. So let's start with ayahuasca, because that was kind of your first experience with this. And so what research has been done so far with ayahuasca and eating disorders?
Well, so my team and I have published a couple of research studies on ayahuasca and eating disorders. We interviewed men and women who experienced ayahuasca, and as a result of their experience of ayahuasca, also experienced healing from an eating disorder. And just in broad strokes, what people talked about was that they experienced deep healing that was very meaningful, but that also was biopsychosocial and spiritual. So that the healing was not only embodied in that they experienced the healing throughout their body, and I'll give you an example of that, but that it was also holistic, that it touched upon physical issues. It touched upon psychological issues, relational issues, but also spiritual issues. So I'll give you an example. One woman shared that she'd had experiences in treatment of employing positive affirmations, to help her get through difficult times.
Yeah.
Like, I am lovable, I am lovable, I am lovable. And then she had an experience with ayahuasca where every cell in her body lit up with the knowledge, I am lovable. And what she shared was that, ayahuasca moves these truths from our minds into our bodies, into our hearts, so that they can never be shaken from us. That's how she described it. Another way it could be to describe it could be like it reconnects us to our truth in our bodies, in our cells, in a way that can never be shaken. So that was really wonderful. There were some issues though. Some people talked about ayahuasca, you have to do a preparatory diet.
Yeah.
That is quite extreme for some, but it also mirrors a diet that someone with an eating disorder might want to follow.
Yes.
And so, some of the participants did say that it was triggering. And I've since observed that over the years, people have struggled, with the triggers of the diet. And so that's kind of, I'm always thinking about practicalities. Like, okay, well, when we are able to lead our first ayahuasca retreat legally, then we're going to have to build in some really good supports around the prep diet, or we're going to have to work with the ceremonial leaders to see which aspects of the prep diet are absolutely necessary and which ones we might be able to work with differently, in light of these individuals' challenges. And then we did a follow-up study where we looked at interviews where the men and women had been in formal treatment, and we asked them what was different, about ayahuasca. And just a couple other highlights were that they talked about it being a lot deeper and a lot more efficient.
Yeah.
Many people talked about the emotion focus of the symptoms also, and the fact that they couldn't escape. One woman said, it was the first time in her life that she was experiencing such profound emotional pain, including grief, and she couldn't run away from it. She had to ask for help. She had to find her way through, and being able to move through that experience with support made it so that it kind of broke her phobia in some ways of these really, really challenging emotional experiences. But again, the flip side of that anecdote is that it also speaks to the need to have really good support in place. And that's not always the case. One woman we interviewed revealed that she was sexually assaulted at the end of the ceremony. So those studies were really important because I feel like they showed us a lot about the potential. They showed us a lot about the risks and the potential dangers, which then will inform how we can create interventions that are safe and, potentially extremely powerful. So we're just in the process of publishing a couple of other studies, one of which we interviewed ceremonial leaders of ayahuasca, so shamans. And we asked them about their experience treating eating disorders with ayahuasca and what did they see? What did they know about this illness from a shamanic point of view? And this study has been just absolutely fascinating because there's actually a lot of overlap in terms of how conventional healthcare understands these illnesses, but there's also some pretty significant disparities that I think we can learn from. And the biggest one was around spirituality. Most of the shamans that we interviewed talked about eating disorders representing a spiritual void.
Right.
And when we look at eating disorder treatment centers around the world, very few have a specific and deliberate focus as a primary pillar, of spirituality. And I think in part that's because there's a lot of religious trauma around the world.
Yeah.
And so we don't want to impose spirituality on people because of the harms that some religions have done to many people. But in a way, we're really, really missing out on a very important aspect of healing. And that's the connection to something greater than oneself. And when we look at the recent research that's coming out of Johns Hopkins, Imperial, but when we're looking at end of life anxiety, smoking cessation, alcohol cessation, people who have these peak experiences are having experiences that are considered spiritual, that are considered transcendental, that kind of help us connect to universal love or this experience of oneness. And that seems to be a big predictor of symptom reduction.
Yeah.
And so whether or not we use psychedelic compounds, what we're already learning from the psychedelic research is that conventional psychotherapy, conventional healthcare even, not just for mental health issues, but for physical health issues as well, we are missing this focus on spirituality in a way that feels comfortable for people.
And I wonder, is that connected to, I don't know, science feels like it's the opposite of spirituality and talking about things like oneness or love or whatever feels, and it shouldn't feel this way, but it feels like that's not scientific.
That's right. That's right. And that's what we're trying to change, and that's why I'm really active in this love project, looking at the scientific inquiry around love as a healing technology. And, spirituality has already benefited from this renaissance, in terms of being seen as unscientific. Now there's several studies that are happening in psychedelic world and outside of it that's showing no, this can be quantified in a way that makes sense to us.
Yeah.
And it is predictive of positive health and mental health outcomes. And so I'm really hoping, along with my colleagues, to do the same thing for love.
Yeah. And with just ayahuasca in particular, because it has this long history and it's done in a ceremony, like, is there going to be a situation where it kind of becomes more westernized? Like, I don't know what the goal is with it. Like, is it to move it into a different context, the way that you've been able to do research now with psilocybin or MDMA-assisted therapy? Or is it always like, no, we need to keep it in that context?
I think that we can't afford to exclude any and all possibilities. I think it's the way that we do it that will that will determine its integrity. I do think that we need to be informed by our native peers who use these medicines as part of their culture ceremonially, to help us to figure it out. But I don't want to exclude any possibility, because people are dying from eating disorders every day, and there's controversy around laboratory experiments of ayahuasca versus ceremonial. And I'm thinking, we do need to consider how we do this. We don't want to repeat the mistakes of our colonial past. And also, there must be another way. There must be a third way, a fourth way, a fifth way of bridging these medicinal contexts to be able to support our fellow humans who are suffering. And there's this really, really beautiful prophecy, and it's called the prophecy of the eagle and the condor. And I really encourage your listeners to Google it.
Okay.
The prophecy states that after destruction from the eagle people, who represent science, industry, productivity, and harm upon the condor people, who represent heart and community and connection, that there will be a time where the eagle people who took over will have become sick and in need of the condor people's help. And that the eagle people will go to the condor people with humility, asking for help, and that the condor people, despite all that was done to them, would be willing to share their wisdom and their medicine. And this prophecy was written, many, many, many years ago, and we're actually at the beginning of the prophecy in terms of its coming to fruition. And we're seeing it, which is really kind of cool, that the indigenous people are opening up their hearts to Westerners to help us heal. They are wanting to teach us. Most of the ceremonial leaders that I interviewed for the ayahuasca study were trained by Peruvian elders.
Yeah.
And right now I'm learning a ton from Navajo elders here in the United States, and these people, despite everything that has happened to them, are wanting to help. We just have to do it in a really, really good way. And we're learning how to do that. There are many more conversations about this topic than there have ever been. There need to be more, obviously, but it's moving in a positive direction.
Nice. And it's interesting to hear you say that, because I recently read Michael Pollan's new book on This is Your Mind on Plants. And the final chapter is about mescaline, and a lot of that focused on the tension of, like, should this be done by Westerners? Should we be even talking about this and focusing on this? And should they be allowed into ceremonies? And it felt from reading that book that it was a lot more guarded and there wasn't as much openness.
Yeah, well, I've had a different experience, and I don't know why that is, but I think I'm hopeful.
Nice. Okay. Well, that's nice to hear, and is really positive.
Mm-hmm.
And so then what about MDMA? And so I know you're the clinical investigator and the strategy lead for the MAPS study. And so, talk about your role in the study and what's happening with that.
So we've identified, 3 study sites, 2 in Canada, 1 in the United States. And we're going to be exploring the potential of MDMA-assisted psychotherapy for anorexia nervosa, but also for binge eating disorder, which I'm really excited about. And we have FDA and Health Canada approvals. And so unfortunately, because of COVID, we experienced some pretty significant delays, but we're hoping to enroll our first study participants this spring. And there is a caregiver component, which I'm very happy about. And so every study participant is also going to be accompanied by a caregiver, family member or close other, who is also going to be involved in the study, not receiving drug, but they're going to be part of the prep session, some of them, integration sessions. They're also going to be provided with education and support, informed by EFFT throughout the study protocol.
Nice. And so will you be in sessions with people as part of that, or it's more of like an organizational role that you're having?
Yeah, so I wear a few hats. One is in the the study design. I'm also going to be a study therapist and providing some supervision to the team. And
as part of this, like with MDMA-assisted therapy, my sense is from what I've read, and there's a documentary that I watched that I'm blanking on the name of, that was on, I think it was set in Israel, looking at MDMA-assisted therapy. Do you know the one I'm talking about?
Sorry, yes, I do. Mm-hmm.
Yeah. Do you know the name of it?
Yes, it's about something about compassion.
Okay, it's fine. I'll add it in later. But yeah, from watching that, my sense is that the therapist is much more involved when someone's on MDMA, and it's much more involved with the therapist than with the ayahuasca. Is that an accurate take on it?
Yes, absolutely. Yeah, with ayahuasca, it's much more of an internal experience unless someone needs support. With MDMA, the relationship with the therapist is actually one of the most potent mechanisms of healing.
And how far off do you think it will be before MDMA is, legalized for use in therapy? Like, are you thinking the next 5 years, the next 10 years? Like, given, like, if everything goes...
Yeah, no. MAPS has forecasted that in 2023, it will be legal for use in certain healing settings.
Okay.
We're very close. We're very, very close.
Okay, that's awesome. And then the psilocybin study at Imperial College. So can you talk about that?
Yeah, so I'm a collaborator on that. I'm not one of the main players. Meg Spriggs is our fearless leader, and she's been just doing an amazing job. And so I can say what's been said publicly is that they have completed a few participants. I can't say more though about it, but I can tell you that we're excited about things that are being learned as a result of that study. And I believe they're still enrolling. And so if people are in the UK are interested and they believe they meet criteria, they can check it out online. So yes, it's a psilocybin study, like you said, and they've also included a caregiver, a support person as part of that protocol, which is wonderful. And it's going to be really great to have these two studies because MDMA and psilocybin are very different substances, and so we're going to learn a lot about potential new treatments for eating disorders, more than what the field has seen in, I don't know, maybe ever. Yeah. In a very short while.
Yeah. And do you know the study at Imperial College, is it similar to the one at Johns Hopkins? So I had Natalie, who is the lead for the Johns Hopkins one for eating disorders, on the podcast before. And so she was talking about that and where they're up to. And so, is it a similar study?
Yeah, there are similarities for sure. I mean, the great thing about this is that sometimes in research, people hide their protocols. They don't share their protocols. They stick to their own little corners. But with this, actually, we've had a couple of, maybe more than that, meetings where we've come together to share. Okay, what do you think about this? Which measures are you thinking about using? Which timeline are you thinking about using? And so whether it's been as a group or in dyads or triads, it's really been super collaborative, which I'm really proud of. I think that's the way to go. So yes, there are some similarities, important to have similarities, but there also are differences. And that way we'll be able to kind of glean more from the studies.
Yeah.
Because of that shared and unique potential variants.
Nice. And so has MAPS given an estimation of when they think psilocybin will be legalized for therapy?
Well, MAPS's primary focus is on MDMA.
Okay.
And so with psilocybin, we don't know. But last week in Canada, there was a major move by the government to approve psilocybin-assisted psychotherapy in some specific cases.
Okay.
And so, I really think that if we predicted, we'd probably predict too far off because things are moving rapidly.
Yeah. Wow. That is very encouraging. And so then the final psychedelic is ketamine. And so, what research have you done around this, or have you used it in therapy in your current practice?
Yeah, so I conducted a study with colleagues last year looking at a model that I developed, ketamine-assisted, emotion-focused ketamine-assisted psychotherapy. And it involves aspects of emotion-focused therapy, but also emotion-focused family therapy. So naturally, we had caregiver support. And it was a short-term protocol for people with anorexia nervosa. We also did a study with depression. And people participated in ketamine, but they also participated in emotion-focused therapy. Their caregiver participated in a couple of EFFT sessions. And it was a safety, feasibility, and preliminary outcome type study.
Yeah.
And what we found was that the ketamine was very well tolerated. Participants found it to be very beneficial, but the caveat there was that they really found it to be beneficial in conjunction with the psychotherapy. Yeah. And that the involvement of their loved ones was very much appreciated. And most of the loved ones who were involved talked about major benefits that they themselves experienced, personally. And so we're in the process of looking at that data and writing it up. Yeah, it's incredible. And it's encouraging because ketamine, though it's not considered a psychedelic, it's a dissociative anesthetic. At the right dose, it can offer psychedelic experiences, which can be meaningful, if held in the right way. And it's much more accessible. Although I would say, though, that from what I'm seeing kind of more broadly in clinical practices is that ketamine is being used more as a medicine, not as a substance that assists psychotherapy. And so I'm really hoping that as time goes on, as we continue to evolve, that it steers more clearly in that direction.
And when you say more as a medicine, you mean the ketamine is being administered and it's like, okay, the ketamine does the work and that's kind of
right.
it.
That's right. Yeah. Yeah.
And I mean, so far we've talked about psychedelics and eating disorder recovery, but obviously they can be used for so many other things. And so I know your focus so much is on eating disorder recovery, but you've obviously had your own experiences with ayahuasca. And so, do you feel like this will be something that will become much more, again, if all the research goes in the right direction, but it will become much more commonplace in kind of psychotherapy more or psychology more generally?
Absolutely. I mean, there are so many studies that are being conducted in different areas of psychologies. Right now, in order to get FDA approval, you need to have a diagnosis. You have to have a clearly specified diagnostic indication. But I do think, I've been seeing it, in all kinds of different ways, that the potential is far broader. However, not everyone needs psychedelics.
Yeah.
Not everyone responds well to psychedelics either. So I think that our work is going to be in identifying what works for whom.
Yeah.
And having algorithms to kind of establish that. And even like, I think about like people who have a high level of anxiety, I probably wouldn't suggest ayahuasca as a first step. I'd probably suggest something like MDMA so that they can cultivate, inner safety and trust with others. So I think that, we're going to be having to think about like all these questions. But first we need to look at safety.
Yeah.
And then feasibility. And then we'll start to look at outcomes and how to understand the outcomes based on different clinical populations, but also personality characteristics, inner, external resources, factors like that.
Yeah. And I think it's just the same as with, there's lots of different types of therapy. There's lots of different things that you can do for trauma. And it's not to say that we need to find the one to rule them all. It's more like, okay, what people respond best to this one versus this other one, and just having that as a tool available.
That's right.
And I, again, like from reading Michael Pollan's work and from my own like personal experience, like I do think that this would be useful for, I think it's also just a strange thing to say like healthy normals, because the reality is everyone has their own shit.
Of course.
They're dealing with. And just because it hasn't reached some degree that is diagnosable, or they haven't been able to articulate it in a way that means that they're getting labeled in a certain way, doesn't mean that everyone's not walking around with stuff that they're dealing with. But I just participated in an MDMA-assisted psychotherapy study as a healthy normal. Yeah.
I was the participant, I took the drug. And there was not a shortage of material.
Exactly. Yeah. Yes. But there is a part of me that wants it to then be available for that as well. It's not just at the extreme end of things.
That's right.
Well, look, this has been a fascinating conversation. I feel like we barely scratched the surface on so many things, and there's so many other areas that I would love to have chatted with you about. But yeah, thank you so much for your time. Where should people go if they want to find out more information about you?
They can check out my website, dradelafrance.com. And there are links to, the descriptions of the different studies, links to the different resources, including trainings if they're interested. But yeah, that's probably the best place. Thank you so much for having me, Chris. It's been a delight to chat with you. I really appreciate your openness and your enthusiasm about these alternative treatment models.
Perfect. Well, yeah, thank you so much for your time. I hugely appreciate it. So that was my conversation with Dr. Adele Lafrance. She is doing just incredible work, and I highly recommend checking out the show notes for all the links to her books, her various websites, and the link for the psilocybin trial at Imperial College for anyone who may want to apply. So I want to make a recommendation for something to check out. There was a while when I was doing this at the end of every podcast episode, and then it fell away, but I want to bring it back. A couple of weeks ago, I released my end of year roundup for 2021, looking at my favorite books and documentaries. And as part of this, I made a request for listeners to get in contact and share with me your favorites, and many of you did. And it's been awesome to hear what you enjoyed. And I bought some of the suggestions so far and added others to my Amazon list. So I intend to get through many of them this year. And one of my clients actually shared with me her reading list for the last 2 years and asked if I had read One Long River of Song by Brian Doyle. And I hadn't, and I wasn't aware of who Brian Doyle was, but I bought it this week. It turned up and I have been blown away by it. It is a collection of short stories and essays and poems, and it is just simply beautiful. He has this unique way of writing with very long sentences. Sometimes a whole page is just one sentence, but his choice of words and his descriptions are just gorgeous, and the content is beautiful as well, talking about the natural world and parenting and love and grief and nostalgia and so much more, and just kind of weaving all of these things in together. And I had many moments of reading it being on the verge of tears, and then like moments later having genuine laugh out loud moments. And he really has a style all to his own. or at least that's the way it appears to me. And maybe I just need to read more, and then I will find other people that he is like. But at this stage, I can't think of another author to really compare him to. And I've nearly finished the book in a matter of days, and will be ordering more of his writing as soon as I'm done. So if you're looking for something beautiful and moving to read, then please check out One Long River of Song by Brian Doyle. And thank you, Elizabeth, for your recommendation. I will definitely be making my way through more of your books, or more of the books on your lists. So that is it for today. I will be back next week with another episode. Have a good week, and I'll catch you soon.